Hi everyone, my name is Valerie Calloway, and this presentation is to inform nurses about a life-threatening emergency called malignant hyperthermia. I'm an operating room nurse. I've been working in the operating room for a little over 2 years, and in all that time I haven't seen a single episode of malignant hyperthermia. However, we question patients about their family history and any medical history that might lead us to believe that they might be at risk for malignant hyperthermia. Malignant hyperthermia is an emergency event that can be life-threatening if not treated early and quickly. Malignant hyperthermia, or MH, is an emergency event that must be recognized and treated early. It's a physical response to anesthesia gases and a paralytic medication in the operating room. Those who have variations of the RYR1 and CACNA15 genes are at higher risk of developing malignant hyperthermia. These genes produce proteins which assist in the movement of calcium within muscle cells. When an MH event is happening, the CACNA15 protein has triggered the RYR1 channel. When this channel is open or active, calcium ions fill the space within muscle cells. This causes the muscles to contract. Mutations in these genes lead to the RYR1 channel to be opened easier and close slower. This allows a buildup of calcium ions, which leads to increase in body temperature and acidosis. Muscle rigidity also results because calcium ions stimulate skeletal muscles to contract. However, studies continue to try to identify why nearly half the people with MH do not have mutations. As I was doing my research, I came across a few statistics that I would like to share with you. According to Medline Plus, there are 1 in 100,000 episodes of MH in adults and 1 in 30,000 episodes in children using anesthetic gases or paralytics. However, these figures are conservative because it is believed that many MH events are more subtle and go unnoticed or unreported. MH occurs in every ethnic group and all around the world. According to MHOUSE, or the Malignant Hyperthermia Association of the United States, MH was first described by physicians in 1960 in Australia. MH occurs twice as often in males as it does in females. 45 to 52% of MH events are in children under the age of 19. The risk of MH is caused by a gene that is inherited. Thus, family members may carry the gene and pass it along to future generations. If a person is aware of a family member with a history of MH, they can be tested for the markers themselves. 1 in 2,000 patients have the gene that contributes to MH events. For obvious reasons, in the operating room, during a history and physical that's done in the preoperative area for patients, the MH questions are one of the biggest questions that we ask. We want to make sure that they themselves or any close family members have not had any kind of adverse events related to anesthesia. This is one of the things that we can do to protect our patients and be prepared for any possible adverse event. In the operating room, we use something called anesthetic gases, much like when you go to the dentist office and get your wisdom teeth pulled and you get that wonderful nitrous oxide that gives you that goofy feeling. All those videos that you see on the internet of people talking funny after they've had an anesthetic gas. Certain anesthetic gases, though, have been linked to MH events. One of the most common anesthetic gases that is used in the operating room today is called sevoflurane. It's used before and during surgery to put patients to sleep and keep them asleep. It is supplied as a liquid and is vaporized into a gas, which is then delivered to the patient during general anesthesia. Desflurane is a similar anesthetic gas. It acts and is cleared more rapidly than some of the other gases, but it works in a similar way. Halothane is also an inhaled anesthetic gas. It may not cause enough muscle relaxation, so an additional muscle relaxing medication may be needed. Enflurane, an anesthetic gas, was taken off the U.S. market because it was linked with causing seizures and increased depressed cardiac activity. Succinylcholine is a muscle relaxant medication that's given IV during induction or intubation and during surgical procedures. All of these medications have been found to be causative factors to people who are predisposed to malignant hyperthermia in having an MH event. Okay, so now we get down to the nitty-gritty. Now that we know basically what MH is and who might be susceptible to it, let's find out exactly what's going on. So how does it happen and how is it treated? As you can see in picture 1, once a substance like the anesthetic gases or the muscle relaxing agents that triggers MH is given, calcium is released and builds up in muscle cells, increasing muscle contractility, almost like they're on overdrive. Then there's an increase in metabolism, which causes an increase in heat, and an increase in O2 intake. CO2, heat, and lactate build up. Respiratory and metabolic acidosis ensues, which causes breakdown of the cell's energy supply, leading to cell death. Treatment of MH will be covered later in the presentation. As you can see in slide 3, the drug dantrolene is introduced. So we know that people who are susceptible to MH have genes that are changed or different in some way. And some of the disease processes that people might have that might contribute to having this gene that makes them susceptible to MH are central core disease. Central core disease is a disease that affects skeletal muscles. When you have central core disease, you can have weakness that ranges from almost imperceptible to very, very severe. King-Denborough syndrome is another syndrome that's a congenital myopathy disease. It causes skeletal abnormalities and dysmorphic features. In the US, less than 1,000 people have the disease. Multiminicore disease also causes skeletal muscle abnormalities. Muscular dystrophy consists of 30 diseases which result in weakness and skeletal muscle degeneration. Myotonia is a neuromuscular condition which makes it difficult for muscles to relax. All of these diseases predispose patients to be at high risk for an MH event. As you can see, they're all very much so related to muscle weakness and the genes that affect the calcium buildup in muscle cells. Okay, moving on. Now that we know a little bit about MH and how it's caused and who's at risk for it, let's find out what you're going to see. How can you recognize that you are in an MH crisis? Hypercarbia, which means increased end-tidal CO2. End-tidal CO2 is the amount of CO2 that's released after you exhale. This is measured using a CO2 sampling line connected to the breathing circuit during surgery. An increased CO2 level is usually one of the first signs that you'll see in MH. Generalized muscle rigidity also happens because of the increased calcium, which causes all of the contractility in your skeletal muscles. You may see masseter muscle rigidity as soon as intubation starts. This might be the first sign of muscle rigidity that you see. Cardiac arrhythmias can also happen due to the imbalance in electrolytes. Core body temperature should be used to monitor for hyperthermia. Hyperthermia is a very late sign of MH and can happen as early as 15 minutes after onset. As you can see, this is a very rapidly moving emergency event. Rhabdomyolysis occurs due to the destruction of muscle cells and subsequent release of muscle proteins and electrolytes. The muscle protein myoglobin builds up and causes myoglobinuria, which makes the urine look a brownish color. Rhabdomyolysis can lead to kidney and heart damage and even death. All right, so now you have a patient in distress, you have an emergency on your hands, and it's a really scary thing. So what do? Now that you suspect, based on the symptoms that you see, the patient has MH, what do you do? If you are the nurse caring for an MH patient, the very first thing that you do is get help, and lots of it. Get as many people as you can because there will be plenty for everyone to do. Just like you would send for a crash cart in a cardiac arrest situation, you would send someone to get the MH cart. An MH cart carries all the necessary items for managing an MH crisis. If you are in an outpatient setting, you also need to call 911 immediately. Next, you would call MHOUSE, or Malignant Hyperthermia Association of the United States. They are the experts in MH, and they will guide you through a crisis. Anywhere MH triggering agents exist, an MH cart should exist as well, as the number for MHOUSE. What you're going to do is notify the surgeon that he needs to stop the procedure immediately if possible. The anesthesiologist should stop all triggering agents immediately. The patient needs to be hyperventilated right away. This may mean using a bag valve mask. The next is dantrolene, the miracle drug. Dantrolene is the reversal agent for an MH event. Dantrolene will be discussed further later in the presentation. Okay, so now you've got this event started and you've got people scrambling to get all the things that you need. In the MH cart, most of it should be available. You're going to assign a person to start an arterial catheter to monitor blood gases, acid-base balance, creatine kinase, serum myoglobin, and clotting times. You have to have somebody applying cooling measures as needed for temperature greater than 39 degrees Celsius. You can use ice or ice packs or lavage. Ice packs can be used in the axilla and or groin. If a cooling blanket is available, you can also use that. Cooling measures can cease when the patient's temperature remains below 38 degrees Celsius. You're also going to have someone place a Foley catheter with temperature monitoring so that you can monitor urine output and core body temperature. And here we go with that life-saving medication, dantrolene. Dantrolene comes in two different varieties. The first one is called Dantrium or Revanto, and it comes in 20 milligram vials, which are reconstituted with 60 milliliters of sterile water. Ryanodex comes in 250 milligram vials that are reconstituted with 5 milliliters of sterile water. You must start a large bore IV at once. Dantrolene is given IV at 2.5 milligrams per kilogram rapidly. So if you have a 100 kilogram patient, you are going to be giving 250 milligrams of dantrolene. The dose can be repeated until the end tidal CO2 decreases, muscle rigidity has decreased, and the heart rate lowers. As you can see, mixing dantrium can be very time-consuming due to the large volume needed for reconstitution. Several nurses are needed to reconstitute the medication and rapidly push the drug. Ryanodex has a much higher concentration with a smaller volume of sterile water for reconstitution. We had an MH drill at work one day, and there were 6 nurses reconstituting the dantrolene using dantrium. And we went through many vials, many syringes, and with 4 or 5 nurses mixing and pushing the drug one right after the other, we still could barely meet the minimum dose within the time allotted. So be prepared and get everyone to help. So now that you can see there are so many different things that are going on with the body that you're going to need to manage, that you may have to have multiple IVs in order to manage an MH crisis. While pushing dantrolene, you also need to manage any abnormal labs. If the patient is hyperkalemic, potassium level greater than 5.9, then you need to give calcium chloride 10 milligrams per kilogram with a maximum dose of 2,000 milligrams, or calcium gluconate 10 to 50 milligrams per kilogram. You're also going to give sodium bicarbonate 1 to 2 milliequivalents per kilogram IV. You're going to give glucose and insulin. Pediatric patients receive 0.1 units per kilogram of regular insulin IV, as well as 2 milliliters per kilogram IV of 25% dextrose. For adults, give 10 units of regular insulin IV and 50 mLs of 50% dextrose. Monitor blood glucose levels hourly. For metabolic acidosis, treat with sodium bicarbonate, 1 to 2 milliequivalents per kilogram IV. So So in an MH crisis, how do you know when the crisis is over? How do you know when the patient is stable? There's a set of stability requirements that need to be met in order for dantrolene to be stopped or slowed to one dose every 8 to 12 hours. Stability requirements include metabolic stability for 24 hours. A core temperature needs to be less than 38 degrees Celsius. The creatine kinase levels need to be stable and no evidence of myoglobinuria present. Muscles must be relaxed and no longer rigid. When all of these requirements have been met, the patient can be moved to the recovery room or to the ICU for further monitoring and treatment. We are definitely not sending this patient home right away. And in conclusion, malignant hypothermia is a very serious reaction to certain anesthetic gases and the muscle relaxant succinylcholine. Quick recognition of the symptoms and fast action in treating the patient will increase the odds of survival of an MH crisis. With the onset of end-tidal CO2 monitoring and the availability of dantrolene, the mortality rate has decreased to 6 to 10%.